And good afternoon. I'm Dr. Ari Dukmajian, CEO and founder of the Duke Spine Institute, and I'm here with the team at the operating room at Duke Spine. We have a patient who's here with thoracic pain. He has a herniated disc T6-T7 on the right side. He's had pain for years. Nobody else has been able to do anything to help him. He found the Duke Spine Institute and saw some of our videos on thoracic Duke laser disc repair, which is a posterior transforaminal approach to the disc. And he traveled here from the Carolinas to have his back fixed. So right now we're using the x-ray machine to localize. And can you see the x-ray, Arias?
Yes.
That's an AP thoracic, front back. That is the metal instrument there is pointing to the pedicle of T12. We know it's T12 because you see the rib. Show us the rib. Yep, that's the bottom rib. Look at the next pedicle. There is no rib. That's just a transverse process. So because there is no rib, that must be L1, and the one above must be T12. And then 11, 10, 9, 8. So stay there. I'm going to move up. So T12 should be 11, 10, shot. And then 9, shot. So that's 9 right there, shot. And let's go fluoro north. And stop. And shot. Too much north. Shot. All right, let's go back south again. I want to be able to look at the anatomy and figure out where we are. All right, cool. It's just slightly south more, slightly, just a half an inch, a little more. All right, so that looks like 12 there, right, at the bottom, wouldn't you say? Yeah. So come up a little bit, just a little bit, like an inch. Stop. All right, so that's 12, 11, 10, and that means I'm at 9. You agree? 9. And then we want to go up, hold on, to 8, shot. That's 8. And let's come north again. 12, 11, 10. And stop. 10, 9, 8. Everyone agrees that's 8. And go up a little bit further. Keep going, shot. So we're still at 8. Keep going. Stop. Still at 8, 7, 6. So I'm at 8. Everyone agree, shot? That pedicle is 8. We all agree? So then the next pedicle would be 7. So I'm going to go up to 7. Shot. Shot. Right there. That's 7. Everybody agrees? Shot. So the disc I want is 6, 7. We all agree? The one above my pointer. Yes, sir. Yes? Yes, sir. All right, so that's where we need to be. I'm going to keep this here. And let me have a needle. No, I don't care about local right now. So I'm going to come off the midline. Shot. All right, so the needle is heading right towards that disc. Shot. Too much. Shot. I'm on the facet. Too medial. And shot. That's looking a little bit better. Oh man, the rib. Shot. All right. So that is the disc. We need to go with a lateral. So a lot of this surgery is going to be going back and forth, trying to figure out the level. We're going to use, you guys need to be making sure the arm boards are far enough north. You guys, this had to be done before we even started the surgery. Luis. That's something you have to make sure is the arm boards are far enough north.
I don't think it's the arm board. Is the arm board the problem? Or is okay, try it now. Nope. Okay, it's on. Try it now.
Oh boy.
No, I can't really move his arm up that much more because that's not the pressure is.
Move south, Jordan, for God's sake. Seriously, I have to tell you that? Yeah, that's fine for you, but it may not be fine for me. Yeah, it's not fine for me. You guys got to check the arms. All right, that I can live with. It's overexposed. What is it?
Yeah, saying this one is good over here, it's just that one.
Shot? 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 All right, we need to make sure this is the right level. So let's go back to an AP view. I can live with the lateral where it is. But you guys really need to make sure the arms are far north when we do thoracic surgery, okay? All right, that's looking good. But let's just verify. Come down a little bit. That looks like 12, 11, 10, 9, 8. All right, so go back north. So that rib on the right side of the picture, 12, has a little bump like a shoulder. So that's its design. So 12, 11, 10, 9, 8, 7, 6. Everyone agree we're at 6, 7? Okay, so if we're 6, 7 and we're supposed to be doing 6, 7, we're doing the right level. And the AP and lateral look good. We're almost at the disc. So keep going. Arias, are you getting the AP view there?
Yes.
All right, let's go lateral. So we're almost at the disc. Everything is going well. How are the lungs? You want to check the lung fields, please? Check the lung fields. Just make sure we're good, because the one thing we can do is have a pneumothorax, and we don't want that. Okay? We don't want to collapse a lung. So that and a spinal cord thing. Let me know when you're in position. That looks good. You doing all right, Berndes? Yeah? Yes? Huh? Shot? All right, it looks like I'm just about at the back of the disc there. Hold on. Don't get your panties in a bunch. Shot? AP? Looks like we're inside the disc. Can't we do a better lateral than that, or are you far as north as you can go? Yeah, just an inch. Shot? That's perfect. Give me an AP. So we are now transforaminal, right side through the foramen into the disc at, is he awake? Let's wake him up. How long till you wake him up? I like to do a discogram. I mean, if it takes too long, no, but if it's reasonable.
Can you open your eyes for me?
Okay. We've lost 1 drop of blood this whole surgery, and you're watching literally the history. Huh? 5 minutes? We'll be done in 5 minutes. Never mind. All right, get ready. Give me a nice lateral shot. Here we go, little injection shot. All right, there's our discogram. You can see his tear in the back. Show us the tear. That's right. No, keep going. That whole thing, there you go. That's the tear. That's where his pain's coming from. We're gonna go clean that tear out, keep him asleep. We will not do an evocative, we'll just do a chromodiscogram. Okay, so now, can you see this? Let's get some light on. Arias, can you see the eye in the sky here?
Yes.
So literally we're the first in the world to do this thoracic transforaminal endoscopic surgery. And you could see how far off the midline I am. It's around 2 finger breaths. You could start a little bit further lateral if you want, but I think this is fine. This is going to be done with a 4mm scope tube. So we don't need a big incision. It's just like a cervical, but the skin is pretty thick back here. You don't want to plunge because you'll end up, you know, potentially being in the lung fields. All right, now we're going to take the needle out and leave the guide wire. And we're going to come down, and I'm going to use this dilator. Do you see this dilator? I need to hear from you, Arias.
Yes.
Okay. Dilator is going to slide down the guide wire, and lateral shot. You can monitor the dilator going down to the disc on the lateral view. Shot. Blood pressure is good. Shot. Turn off the lights. All right. I mean, not that much. Shot. All right. Almost there. We're just lateral to the spinal cord right now. Shot. We're at the back of the disc. I can feel it at the annular tear. Shot. I'm going to just one more shot. All right. I'm going to try to push the dilator through the annular tear because I want to keep my guide wire there. Shot. It looks pretty good. Hold on. Just a little bit more, and then I'm going to use the mallet. Shot. I'm in. Yeah. Yep. Take it out. So now I'm going to use the mallet to advance, and we're in. So we're inside the disc at T6-T7 through the tear. Now I'm going to drop the tube. You guys see the tube here, Arias?
Yes.
It's a 4mm tube. We're going to do the whole surgery through a 4mm tube. This poor man has been suffering with horrible pain. Nobody's been able to help him. The surgeons all turn him away. The pain management doctors have nothing for him. And we've done now about 17 of these surgeries. Shot. Endoscopically. And all 17 patients, on average, 99% elimination of their pain 1 year after surgery. Shot. Yeah. Just over a year. All right, we're inside the disc. Get it out. We're ready to get started. Shot endoscopically. So one more shot. That's it. Let's get a nice picture. Come on. There we go. What makes it nice is when the patient's in between respirations, when they're not inhaling or exhaling, because if he's moving his chest wall, then you're going to get a blurry x-ray. So you want the patient to be fully inspired or fully expired, kind of in between breathing. Why is there a white light flashing down there at the base of the fluoro? See that?
I think that's just the tower.
All right. So far, so good. Everything's going well for this patient. And we're going to be done in about 15 minutes. Maybe 10 minutes. Scope's going down. I need scope on. Let's switch to the scope feed, Arias. And there it is. We're inside the disc. You see the blue dye? That's staining the nucleus pulposus. And that's degenerated nucleus. That's, I need the laser on. Is it ready or not? Hello? Yes, no, maybe so. Jesus Christ. Why do we wait so long? Any questions from our audience, Arias?
None at the moment.
Yes, no?
None at the moment.
All right. So this is why he's in so much pain. He's clearly got, bring the exposure down one. Fucking hell, man. Are you serious? Oh, is he sleeping? It's one herniation. Look at the tear, though. You guys see the tear between the white fibers and then the blue stuff stuck in the tear? That blue stuff is the nucleus pulposus stuck in the annulus tear. Hey, the exposure's too high. I just said bring it down a notch. Do we bring it down or not? Huh? You did? Okay. Thank you. Oh, nice. Teamwork. Teamwork makes the dream work. What a tear, huh? Look at that thing. No wonder why this poor man was hurting. Of course, there is the tear. You can see it on both sides, front and back. And look at him breathing. Did you see him taking a breath? It kind of moves right there. You guys see that? It moves with his breathing. Right there. Exhale, inhale. Exhale. You guys see the walls of the disc moving with the breathing? It's pretty cool. This is great stuff. What a tear. What excites me the most is the surgery is going really well for him, and I can't wait for him to wake up and tell me this pain is gone. And my God, the only surgeon in the world that can do this. Soon my son will be doing it and helping people just like I have. Hopefully. All right. Any questions? Let's flip it. So what I'm doing is I'm going back and forth because the tear, remember, it starts in the medial and goes to the lateral. So I'm cleaning it out on both sides, front and back, as I pull out my tube. So I'm pulling the tube out slowly, gradually, and I'm cleaning the tear as I do that. It's honestly not that hard. The hardest part of the surgery is getting in to the disc without paralyzing the patient or dropping a lung. You don't want to drop a lung. Then you got to put a chest tube, send them to the hospital. They're going to have to stay in the hospital a few days. We call that a pneumothorax.
If you dropped a lung, you wouldn't see that movement, that disc movement.
Yeah, probably. If only one lung's ventilating. Or we could see it more. There's a herniation. I just floated it up and out. Almost done. We got about 5 minutes left, doctor. 5 minutes. I'm telling my anesthesiologist I have 5 minutes because I want him to be able to wake the patient up on time. If you don't communicate with your anesthesiologist properly, then the patient's going to stay asleep, and they're going to sleep for like another hour after you're done with surgery, which is not really good for us or the patient. All right, just about done here. I keep pulling the tube back. That's what you see me. I'm wiggling it, and everyone can see the tear, right? Any questions from our audience, Arias?
Yes, one question.
Okay.
We have a question from JJ. JJ asks, what is annuloplasty? And also, what is the difference between the laser and radiofrequency ablation tool for the disc?
Great question. So radio frequency is where you deliver energy through a piece of metal, and basically you burn whatever's at the end, like a barbecue. The laser is a far more precise tool. It uses a better energy, cleaner energy. You don't see any burns. It basically vaporizes the disc and it creates a cavitational wave. So a radio frequency probe doesn't create a cavitation wave, so there's no mechanical disruption with a radio frequency probe. Plus a radio frequency probe, you can't manipulate it around like I'm doing right now. So I'm moving the laser, tip of the laser, moving it and directing energy to different areas. With a radio frequency probe, usually you just put it in one spot and leave it there and let it burn. And then the first question, Arias, can you repeat it for me? The difference between...
What is annuloplasty?
Oh, annuloplasty.
And also, what is the difference between laser and RFA?
Yeah, so an annuloplasty is when you stick a radio frequency probe in an annulus and you just burn. And that's not what we're doing. We're using a laser and we're directing laser energy to different parts of the annulus, debriding it. So very different. We don't do annuloplasty because it doesn't work. We really do an annular debridement. This stuff you're seeing coming out was stuck in the annulus, and that's what I'm debriding or removing. This will allow the annulus to heal properly in a pain-free state. Great question. Thanks for asking. Boy, what a deep defect, huh? Almost done. 2 minutes. I'm almost outside the disc at this point. Flip it. I just want to say great job, everybody, today. Everybody, thank you for your help. It was a long day. I appreciate it. This patient will be going home in about 30 minutes. Now, this surgery that we're doing is outpatient. And for the longest time, anybody with a thoracic disc herniation had to have open back surgery. The typical surgery is called a lateral extracavitary or a transpedicular approach. These are major, major surgeries. People stay in the hospital for weeks after that surgery. And here we are doing it outpatient. So this is a revolution in spine care. There was a development about 20 years, 30 years ago with transthoracic endoscopic surgery for thoracic disc. And I know Curtis Dickman in Phoenix at the Barrow was doing that. But again, that's very invasive and risky, and the patients had to stay in the hospital after that surgery as well, but usually overnight or for a couple of days. This is far less invasive, far safer for the patient, and there's no hospitalization needed. Now, we've done almost 20 patients in 3 years at Duke Spine. We've published our results. Arias Duke-Majan, my son, as a matter of fact, was the primary author for this study. And we found that the patients had 99% pain elimination from thoracic disc treated with Duke laser disc repair at 1 year post-op. This should be the end of it. We're pretty close to the surface of the disc at this point. I've been pulling back with my tube coming out of the annular tear. This should be the outermost fibers. Let me just flip it one more time. So we still have not big numbers, but 16, 17 patients is pretty respectable. There's not a lot of people with symptomatic thoracic disc herniations. Most of them are lumbar or cervical. Very rare is their thoracic. But since very few doctors in the world treat this condition, they don't have anywhere to go. And Duke Spine Institute will probably remain the place to go for many years to come, since nobody else is doing this kind of surgery. 1 minute. I'm literally at the end of the disc. You can see the end plates, the vertebral body end plates there. This is the last part of the disc right here. The last part of the tear and the herniation. You can see a little bit of calcium there, calcification. Notice that the calcification occurs at the periphery of the tear rather than in the middle. And the reason is it related to inflammation. Inflammation happens more commonly at the periphery where there's blood supply. Remember, there's no blood supply in the middle of a disc. So the further out to the periphery we get, the more blood supply you're going to see. There it is. We're done. There's the back of the disc. Pretty incredible. And the spinal cord is right there at 12 o'clock. That's the epidural space. It's a little bit of red. You could see it. Pretty amazing. Just about done. Oh. Guys, why is the bag not sucking? It's pouring onto my foot. Jesus Christ. Literally, a sea of cold water just landed on my foot. It's kind of distracting. All right. I'll forgive you because I know it's been a long day. It's all right. No problem. I don't care about my shoe. That's it. We're done. All right. Irrigation.
Lights on, please. Thank you.
You see the fat there just outside the disc and the foramen. Little betadine, antiseptic. Any questions, Arias? So it's kind of cool, Arias, that you
Actually,
did this.
yes.
Yeah, go ahead.
We have another question from JJ, or comment, also a question. I have type 1 modic change on my L5S1 annular tear. What does that mean, and is this treatable with your procedure? Question mark.
Yeah, JJ. So type 1 modic changes are basically arthritis changes to the end plate or bone. It's meaningless. It doesn't cause any symptoms. It's just an indication of chronic inflammation related to a disc injury. And this procedure you're watching can fix your pain without fixing the modic changes. Modic changes don't need to be treated. Okay? They're irrelevant. Let me show you all the incision right here, 4 millimeters. You guys see that, Arias? I have to apply a
Yes.
little bit of pressure. Oh, my foot is soaking wet. That's all right. That's all right. That's all right. That's all right. So modic changes are basically erosion of the bony surface, pitting, what are called pits, cysts, subchondral cysts, which are basically spaces in the bone that were not there originally within the cortical bone. You get irregularity of the bony surface. You get the cartilage on the surface of the end plate becomes disrupted, and it becomes thin and flaky, and basically it just starts falling apart. But that has nothing to do with what's causing your pain, and the Duke laser disc repair can fix your pain without doing anything to the modic changes. Arias, you see this?
Yes, I do.
Awesome. 4 millimeters, we'll put pressure for another minute, and then we're going to put a steri-strip bandage, and we're done. This patient will go home in about 30 minutes. Great job. So did you do general or you propofol? Propofol with the air mask? Yeah. Nice. Yeah. Good. All right, guys. Thanks for watching. Arias, you can end the broadcast, and we'll see you all next week. Thanks for
GG.
joining us.